Thank you to the organisers for inviting me. Thank you very much for coming to this conference. I'll say it before someone else does. I don't feel entirely comfortable being one of five men in grey suits on a platform talking to you. No disrespect to my colleagues, but I think we've got a bit of a gender imbalance. So that out the way, let me say the conference is extremely ambitious. I was looking at the program. We're talking about the future of mental health, workforce, children and young people, secure care, CBT, digital, supported living, occupational health, substance misuse, local councils, and perinatal. It's a real cornucopia of challenges and opportunities. So I'm slightly wondering how my presentation on the physical health of people with mental illness is going to land. But what I want to really do is to say that I'd like a broader conversation when we get the chance to speak in the panel. And can I just do this because I can't help it? My mother was a school teacher and I love to see a show of hands. Can I just check to see who is in the audience so I know who I'm speaking to? It's dark out there, but I think I'll see your hands okay without the lights going back on. So who here works for some kind of healthcare provider, and that includes a digital provider? And who works for local government or public health? Great. And the voluntary and community sector? Wow, by far and away the largest sector. Research and academia? Great. And some of you have put your hands up more than once, which is great. And anybody else I've forgotten, I apologize. And you can tell me afterwards, not during the session, about where you're from and what you're doing. Okay, so let me just move on a little bit. So I work for Public Health England. We are your national public health agency. We do a lot of work around health protection, health improvement, data, evidence and knowledge. We are an agency of government, but we provide independent evidence and advice to government and the sector. Our main audience is the public health field, however you define that. So we would categorize everybody in this room as someone who has got some public health expertise and some public health knowledge. And our aim really is to improve the public's health and reduce health inequalities. In the mental health brief, what we try and do is make sure that mental health is something that all of our areas and functions are doing, whether it's emergency response to disasters or outbreaks and the psychological effects of things like flooding and disasters and emergencies, or whether or not it's looking at coronary heart disease or diet and obesity. There's a psychosocial element to everything that we do. So I think it's very important that we don't just see mental health as defined by mental illness, although that's extremely important, that we are much more sophisticated in the way in which we think of mental health. And I'll say a little bit about that before I close. So this is the kind of work that we try and do in the mental health team, along with many, many other of our colleagues across Public Health England. So we are trying to do work on mental health promotion. We're trying to do work on mental illness prevention and suicide prevention. And that has basically been the majority of our work over the last 3 to 4 years. So some of you in the field may know a lot about our suicide prevention work, that we've got a whole set of resources and guidance, particularly the guidance on every local area having a suicide prevention plan by the end of this year. So if you want more information about our guidance, just Google Suicide Prevention, Public Health England. All of that will come up on a page. We've also just published the Prevention Concordat for Better Mental Health, which looks at promotion and prevention across the life course. And we've published a suite of 10 documents, reports and guidance and tools, including a return on investment. So you can choose which areas you would like to invest in that we know will give a return. And that was published on the 30th of August. If you Google Prevention Concordat for Better Mental Health, that will come up. So a whole series of things. The area that we haven't given enough attention to has been improving the physical health and well-being of those living and recovering from mental health problems. That's not because we haven't wanted to do. It's a question of putting resources where we know we can actually legitimately begin to do something. So we've been having lots of conversations with NHS England, all across our organisation in terms of those working on CVD, on screening. And we now have been looking at ways to which we can collect data. So we've got a base point of where we are with this, and that we can actually monitor progress as we go on. So it's not an excuse, but there are some reasons why we're now coming to this, and we are appointing a senior person to lead this work very shortly, and we are very encouraged by our partners' reactions to that, and working very closely with NHS England and others. So this is an area that is the next big priority for us in the national team. Some context. You don't need me to lay out just how gross this inequality in the physical health of people with mental illness actually is. But they're dying from the same things as everybody else. So are we going to look at integrated solutions, or are we going to continue to put things in a mental health, mental illness box and magically expect that further exhortation of the inequalities is actually going to shift things? Whilst we talk about evidence and data and indicators, what we really, really need to see in this area is action. And I think there are some elements of the jigsaw that are in place already, and we need to drive those incentives much harder. But I think there are some things we are really missing that would make an absolutely big difference. We can't talk about the health and well-being of people with mental illness who will increasingly have comorbidities unless we start talking about employment and unemployment, poor housing and homelessness, and the still very, very prevalent stigma and discrimination. So the wider psychosocial determinants are as important as what we might be able to do in services and in public health screening and supporting. So this is that kind of complex agenda. We can't just expect, as we've got, thankfully, more resources coming to the NHS, that they will be able to deal with all these issues. If you're sitting in front of a client who has long-term and persistent and significant mental health challenges, unless you're looking at the wider context of their lives and their ability to function in the ways they wish to function, any amount of sequins or any amount of QOFs aren't going to improve employment status, housing status, relationships, being debt-free, and having those amongst them who love and care and support them. So we need to look beyond diagnosis into functioning. So the 5-year forward view states very clearly that this is an absolute priority and that we need to do much more to make that clear. Whilst it's a 5-year forward view, it really is now a 3-year sprint to the 2021 finish. So it's feeling like we need to start thinking about what comes after the 5-year forward view. And it would be great if the 5-year forward view expanded into what over a quarter of people said in the consultation on the Mental Health Task Force is we need to get much more upstream, and we need to be much more active in the psychosocial elements of this and addressing the wider determinants. So this is good, but we need something that will follow it very, very quickly. So these are the areas that we have a lot of activity in, promoting equal access to cancer and all the other screening programs. We know that for some, people with mental health problems are getting just as good access, and for others we know it's woeful, and we need to do much more to do that. We've got some baseline data on that coming out soon, so we can actually measure and track the extent to which our screening programs are being much more active in actively engaging people with mental health problems and making it easier for them to access screening services. Promoting physical health care, the sequins and the QOFs, very, very important, very much NHS job and also the job of primary care, but we can hold some of the evidence and the data to that to make sure that those are happening. Smoking cessation, we've had a massive amount of guidance on smoking cessation, and we now need to make sure that all mental health units across the country are smoke-free by 2018. We'll publish an atlas of variation, which isn't a naming and shaming, but it's just showing which trusts across the country and which facilities are smoke-free, so we're actively working on that. And I've stressed again addressing wider determinants and that we provide system support to do that. There are a number of areas which I'm going to rattle through, but the NHS health check is really, really important in this. And we need to make sure that people with mental health problems have as equal access to the NHS health check as others. And with your help and others, we are still trying to drive some form of questioning, some form of attribute within the NHS health check that actually asks about mental health and not just concentrates on the physical health aspects. And we're moving slowly and surely towards that, but we do need some better science to get past some of the scientific committees that judge what goes into NHS health checks and what doesn't. So lots of opportunities here to do something more and better. Can I also say on NHS health check and CVD initiatives, we'll be doing something a little bit further, but I'll say something about that in a moment. The other areas are the recommended physical health assessments for people living with serious mental illness. There is a very, very variable picture across the country, and what we'd like to do is try and collect the data and information so we can actually show the variation. In some parts of the country, 90% of people with severe mental illness are accessing sequins and physical health checks. In other parts of the country, it can be as low as 10%. And that inequality in access on this very, very important health check is really unacceptable. So we need to find ways of ensuring the system is doing what the system is asked to do. Primary Care Commissioning Guidance, NHS England will be publishing that soon. And we really do hope that will make a major impact in terms of the primary care's attention to addressing this as best they can. And I think going forward, we want a lot more work around the alcohol and drug comorbidities. We've got lots of guidance, and might want to pick some of that up in questions for those who are interested in the substance misuse angle. And tobacco, I've said an awful lot about before. I'm ripping through these slides because you'll have these to take away. But we do need to make sure that we are addressing smoking cessation and tobacco within mental health and mental health units, but also finding ever more innovative and outreach ways to reach people. So the smoking and mental health program has a number of different attributes to it, but as I said earlier, we really do want to make sure that all the providers are smoke-free. So opportunities, great opportunities going forward, learning from other places. Andy at the Centre for Mental Health Rethink and lots of other colleagues are beginning to look at an equally well collaborative based on the work in New Zealand, which has a shared consensus statement and agreed actions that we can drive into the system. We need to improve data collection and its use in relation to how many people with mental health problems are accessing the things that they have access to. And we also need much more transparency on whether or not people are actually undertaking the guidance and the mechanisms that are in the system to help make sure that these things happen. So we do want to see more emphasis on smoking cessation, the physical health sequin, and primary care physical health. In relation to Public Health England, we've also got some work coming out from the right care work. There will be some guidance on severe mental illness and CVD. That will be produced in March 2018. And my colleague Carly Woodman, who is here and is just about to wave her hand, just up there on the left, will be here all day. I'll be here till lunchtime. We'd love to speak to those who are working in CVD and SMI and get a little bit more opportunities going there. Before I finish, what I would like to say is that there is so much going on in mental health at the moment, which is absolutely fantastic. I think that we need to, in terms of the work going forward, we need to be much, much sharper at differentiating between what we're doing for good mental health, what we're doing to support and respond to people who are experiencing mental distress without biomedicalizing and pathologizing everyday events. And we need to make sure that we are reaching out to those with mental illness in ways that boost and support their recovery. That can't be done without a psychosocial approach. We can't expect the NHS to solve all of the challenges, and we really do need to start working as one system to make the whole thing work more effectively. So whilst the NHS has got a significant investment to improve services, we are also asking councils, local government, and other colleagues to make sure that we don't stop just with an investment in mental illness treatment services. Otherwise, the whole system doesn't work together. We need more research, we need far more implementation, and we need much more implementation science and living ways, if you like, living laboratories of making sure that the things we're doing are actually having impact. And we also need to activate the public more, and we need to have a much more sensible dialogue with the public about what mental health is, what mental distress is, what mental illness is, and what we can do to support not just ourselves and others. So it's a very, very wide agenda. I hope you enjoy the rest of the conference, and I'm looking forward to our conversation in the next 15 or 20 minutes. Thank you.